thank you. It's very nice to be here with you all today. And I was especially grateful to hear our first two speakers set the scene. And Paddy ended by asking what or who is driving centralisation and what is the agenda. And Mary really answered by telling you about the whole role of corporations in commercialisation. And of course Ireland is very difficult because unlike the United Kingdom, it's always had a mixture of public and private interests. But those private interests have been largely not-for-profit or religious, or of course individuals around doctors where there is a profit motive. But we're really embarking on something entirely new. And as Mary indicated, the US healthcare industry is playing an enormous role in the reshaping of health systems right across the world. And that includes universal healthcare systems of Europe, including the United Kingdom, which are at this moment being broken up and privatised, the delivery system, and opened up to corporations. But so too is the funding, with what's called the removal of entitlements and benefits and delisting and increasing use of user charges. So your struggle, you are not alone, you'd be glad to hear, or rather sorry to hear. And one of the things that I was really struck by is the similarity between the strategy of the Department of Health and Children and all the other strategies which have been drawn up across Europe. You'll see exactly the same terminology, the same words, in the same management consultants' hands, as Mary's indicated. And I was thinking today, well, what can I give you that you haven't already heard? Mary's given you a very coherent and comprehensive account. And you've also heard from Paddy that there's absolutely no evidence whatsoever to support centralisation. And that is actually where your government's really vulnerable. Your government is vulnerable on the claims it's making for privatisation and the introduction of for-profit corporations. And that's probably the one most important thing you can take away today when you're campaigning and you're becoming active in your communities, is to keep challenging the nature and the quality of the evidence the government is putting forward. And I was really struck when I came on, I was talking to some of the media people who were saying that the two myths that are being put about is that healthcare expenditure is totally out of control and that the health budget is a black hole. And I think it's very important to examine these statements carefully, because healthcare expenditure is a political decision, but it's not out of control. And where it is out of control is in those countries which have privatised their healthcare system most. So the US is the best example, 50 million people uninsured, 10 million people uncovered, children uncovered, and yet it has the highest percentage of GDP spend on health expenditure. Those with the lowest healthcare expenditure are those which are most under public funding and public provision. And those in the middle are those where you have mixed. So it's a really important thing to remember. And I should have brought you the data, but I hadn't realised how important it was here. So I think it's really important to keep going back to question those figures. The second thing is that healthcare is a black hole. You have to ask, where is the healthcare euro going in Ireland, and how much of it is going out to the pharmaceutical industry, which is unaccountable, probably around 14 to 20% of your healthcare budget. How much of it is going through P3s, and how much of it is going into the costs of the market. the billing, the invoicing, and the transaction costs. Because once you have a market system, and inevitably when you bring in corporations, you have to put in a market system, something like 40% of the total healthcare expenditure will be going out into running the costs of the market, the billing, the invoicing, and the marketing. That compares with a public system where you have really none of those costs, and you're looking at 6 to 12% will be the cost of administration. So I think that's really important to challenge the notion that healthcare expenditure is out of control and that it's a black hole, and you have to keep revisiting those. But today, I want to talk about the big move that's taking place from the patient as a citizen in public health to the old ideals that even Ireland was striving for, even though it did have this public-private mix. Nevertheless, the government was striving to attain universal entitlements, access, fairness of funding and delivery. Never achieved them, and it will never achieve them in any country, even if you have a universal healthcare system, but they're the old ideals, to the new ones, where the patient is a consumer in a marketplace, where the patient is exercising voice and choice. And voice is where you can decide you're going to enter and exit the health service. But if you're a patient knocked over in an accident or lying in A&E, it's pretty difficult to exercise voice. What you want to know is that the service will be there when you need it and of a high quality, and that there'll be good access for all. So really the patient can't exercise voice. And anyway, if you were going to exercise voice, you'd have to have choice, which means that there would be a plurality, many providers to choose from. But in exercising that choice, you would have to accept that there will be inequalities, because some providers are going to be better than others, because how else do you exercise your choice? And only some people can exercise choice, those who are best informed, namely the articulate, middle class, and the wealthy, who have that to do. So if you're a patient as a consumer in a marketplace, you have to think very carefully about whether voice and choice are the best ways of doing it. And of course they're an absolute nonsense, because economic theory tells you that healthcare is enormously complex, and actually you as the patient are generally reliant on the professional to assist you in making those choices because of something called information asymmetry. You can never have perfect knowledge. Unless perhaps you've got chronic illness or disability, you are never going to know in the acute phase what is going to be best for you, nor would you want to make those decisions. But what the government, and your government in particular, are doing in modelling you as the consumer and voice and choice is making you responsible for those decisions, the league tables, the output measures, the performance measures. How are you going to interpret them when indeed they're not interpretable? So these are the two models that you have. You're rapidly moving to patient as consumer in a marketplace. And it means enormous change, and I'm not going to take you through what's happening in England, but I just do want to say that there are enormous parallels between what's actually happening in England and Ireland at this very moment. Scotland and Wales have moved away from the market. They're moving rapidly to try and lock out private for-profit corporations. They're taking a very different direction. But Ireland is modelling itself on England, which in turn is modelling itself on America, the US Health Maintenance Organization, which is where much of the terminology comes from. And of course Ireland has long had a love affair with America, but so too has Blair and more recently Brown. So the American healthcare industry is very strong. That's the model and that's the template that's being imported right now into Ireland. And you're in the middle of it, so it's very, very confusing. It's difficult to understand a lot of what Mary is telling you, the enormity of it. And I'm going to try and these are some of the demonstrations, a bit like yours, that are going on right now in every bit of England. The opposition to the market changes are absolutely enormous. Now, in our stages of privatisation, and some of them you will already have seen, are first, you take away the control away from the professionals, and you put it into the hands of bankers and businessmen and accountants. So there has been a criticism that the board and the HSE board is increasingly dominated by business people with more shareholder interests than public health or healthcare interests. Now, the second stage of our NHS privatisation was the idea of bringing in a market, a purchaser-provider split. So the health boards were got rid of, in effect, and I think that's what's happened recently in Ireland. You get rid of your health boards, you get rid of your institutional memory, your way of organising and planning services, and you centralise not just your hospitals but also all your administration, and you bring in new technical teams, including management consultants, who can help you bring in the market. And that's very, very important. At the same time, you will be bringing in new powers to privatise your infrastructure, your public services. And that's where the P3 is coming in. Now, the P3s could be called a sale and leaseback. You're selling all your hospitals, you're selling your public services, and instead you're getting into long-term contracts with the private sector. You're simply tenants, you're leasing them back from the private sector. And those new landlords have the power to bring in corporations to run pharmacists, diagnostic services, elective surgery, the Royal College of Surgeons of Ireland, whatever. And that's where co-location becomes interesting, and we'll talk about it. But then you're also going to privatise all your frontline services, your staff, and that's what the consultant contract, the GP contract, the changes to the nursing, the new pricing system. Because a market needs a pricing system. You cannot move the public euro out of the public system unless you have a mechanism to do so. And Mary was explaining about the National Treatment Fund. That is a budget that's been set up, but you couldn't start to move the money out unless you have some mechanism for operating a pricing system into for-profit providers. Because when you're breaking up what's left of the public system, you're trying to privatise from within and also move money out into new private sector. So these are the different types of public-private partnership that you establish. First of all, you privatise from within. So your hospitals may be created as trusts and given new powers to get into joint ventures and to bring in the private sector. Or you may privatise directly through commercial contracts. Co-location is a good one. Elective surgery for waiting lists. You say to the private providers, we will give you so much public funds to provide our services. Radiology, pathology, but also general practice. I notice primary care is a big focus. Or you can privatise through your land and your buildings, as I said, through the public-private partnerships, the infrastructure, selling off your buildings, your public buildings, and leasing them back. And finally, as Mary alluded to, you've got privatisation of public administration, where you're actually not doing the planning yourself, but you're bringing in healthcare companies or management consultants to design the government rules, the government standards, to run the information, so it's no longer public information, to design the guidance to government, and to conduct the surveys of patient experience and satisfaction. And that's very crucial, because patient responsiveness and patient experience is very important in this document. And I have no doubt that the government is busy outsourcing patient surveys to make sure they get the answers they want when they're closing the hospitals in Moynihan or wherever across the country. And this will be very carefully controlled and contained. So, these are some of the privatisation policies I've picked up in Ireland, the co-location, the PPPs, and the corporatisation of primary care. So you've got lots and lots of different initiatives going on. Lots of entry points being created, so it's difficult to understand what's happening and to get your head around it. But not only that, you've got to not only understand the big picture, as Mary's doing, and Hattie too. They're telling you about centralisation being a subtext for something else, and also how the private sector is moving in these different privatisation modes. But your next job is to actually look at the evidence. And of course, these are the key claims for using the private sector. That they'll get waiting list staff, they'll bring in additional capacity, new beds, bring in new efficiencies, you'll take the private beds out of the old public system, leaving more, and then you put the private beds back in through co-location. They bring value for money, which means you're transferring the risk from the public to the private sector, and quality and innovation. And I thought I'd use the closest example that we have of co-location, which is something called independent sector treatment centres. And basically these are small private hospitals or private clinics which are either run within the public system or built afresh. It's a type of co-location next door to the private public hospital. They have tax breaks, but they also have government grants. And the private sector was invited to design and build these to take the pressure off the public system, to clear waiting lists, and to do elective surgery and elective care. But very quickly they've been rolled out to include radiology, blood, screening, diagnostic services. So this is the parallel co-location system. And the government has injected the equivalent of, 8 billion euros? A lot of money. 8 billion euros in England into this programme. And these were the main claims. Bring in capacity, get waiting lists down, to bring in new medical professionals. But they'll be from overseas. They'll be additional to the existing health professionals. So they won't pinch our public nurses and our doctors. High quality healthcare and value for money. Sorry about this, it's an old slide. But anyway, what we wanted to do was to look at these claims and the evidence base that underpins them, and question the evidence. And perhaps some of this experience, we've recently published this in the British Medical Journal, but perhaps some of this analysis will help you in the campaign. So one of the very first things was competition, and what we saw was that the public sector was not allowed to compete for any of these contracts. Only the private sector could come in and compete for the 5 billion. But actually we saw very little evidence of any real competition, but quite a lot of sweetheart deals. But let's go into the additional capacity. So we went to the Department of Health because they collect all the data on the public beds. And I noticed that there are big claims being made about 1,000 new beds and 500 beds in the private sector. Maybe I got the numbers wrong. So capacity, what do we mean by capacity? Well, we usually mean beds and staff so that we can do more. But when we went to ask what data were collected on beds, we were told nothing. So every week, the public sector makes a return on the bed occupancy. They do a midnight census of the number of beds and which are occupied and how many are occupied. But these bed returns aren't being made, and for 3 years, nothing has been required from the private sector. So how do we know that there's going to be new capacity? Moreover, we don't even know what type of beds, whether they're 5-day beds or 7-day beds or beds for surgery or beds for medicine. Well, the second thing is that we do know what beds are being collected for the NHS. But what you can see from these charts is that the number of beds are falling dramatically. And since Labour came to power, 23,000 beds in England have closed, and they're still continuing to close. So the whole point of this ISTC programme is to bring in additional capacity and additional beds through the private sector, additional to what there was. What we see is that money has been diverted out, so we have fewer beds in the NHS, but we don't know how many beds in the private sector. So the bed claim of additional capacity can't be supported. The second thing that we asked was, well, what about more staff? You've promised that there'll be more doctors and nurses. So again, we went to the department that does the workforce statistics. And we found that they thanked us for our inquiry, but they said we don't collect any workforce data. And yet, again, the public system has to make returns on every doctor and nurse by category that's employed. So, we made a Freedom of Information request, and we discovered that 25% of the staff was seconded from the public sector, from public hospitals. Moreover, the public system is now so short of money as a result of this £5 billion flowing in, that the Department of Health has published a workforce strategy which anticipates losing 36,000 people. So much for additional staff. Now you'll remember that the Labour MPs were bought off. They were opposed to this private sector development because they were worried about staff being stolen. But they were told, don't worry, these will be additional, and we're going to put clauses in which require them, the private sector cannot employ public nurses or public doctors. Well, what happened? By the time the second tranche of contracts was being negotiated, those clauses were abandoned because the private sector could not operate without taking publicly employed nurses and doctors. So they got rid of it. And at the same time, the public hospitals were losing money intended for them, and so they were having to close their departments of elective surgery, of orthopedics, of ophthalmology. And so the doctors and nurses could no longer find work in the public sector but moved to the private sector, but under very different terms and conditions of service. Now, the other thing that's been very important in England in the National Health Service is this idea of equity, fairness in terms of work, in practice, in terms and conditions. All of that has been deregulated and dismantled. So we couldn't find any evidence of additional capacity of beds and staff. Indeed, quite the contrary, the staff were now being moved into the private sector along with the money. Well, what about these more patients treated? The marvellous thing about bringing the private sector in is they get more and more patients through faster. Well, when we asked about patients being treated, we found that the data on admissions were not being collected, although the public hospitals had to make a data return on every single patient admitted. So it wasn't being collected. There were no data being collected. collected. So we don't know what the private sector is getting £5 billion worth of contracts, 7 or 8 billion euros, and yet they don't know how much or how many patients are being treated. And we found it impossible. Now this table looks meaningless, and it is pretty meaningless. These were the best data that we could get. We could not find, these are for the different years, and you can see that these were from Freedom of Information requests because they could not publish by year how many treatments were being done. And I think the most staggering thing is this program had been running for 3 or 4 years. It was supposed to be treating 170,000 patients a year, but it had only done 107,000 in the 3 years it had been running. And look at the sudden jump. For all procedures, they claim by January 2007, the program had been running 3 years, to have done a total of 170,000, but they were getting a bit worried because of the pressure politically that was growing, and so suddenly they managed to triple their rates. Well, that's unbelievable. Unless, of course, procedures or blood tests or even subcategories of blood tests. So you might do one blood test and look for hemoglobin or platelets or whatever, and you might then be breaking it down. Nobody knows what these procedures are, let alone whether the surgery was being conducted. But they're also adding in primary care procedures, which they were never set up to do. So we've got gobbledygook, and the gobbledygook is now sitting on the Department of Health website, looking very authoritative as claims about what they're doing. Now, this is very important because if you're giving a big contract, you want to know that they're doing what they're saying. And independent sector treatment centres, the private sector, were being given take or pay contracts, which meant they took the money and the public sector paid regardless of how many patients were treated. So they were being told, we expect you to do X amount of treatments, but if they didn't do it, it didn't matter because they'd still get paid. And of course there's no monitoring system, so we don't know what they did really. Now there was a Health Select Committee parliamentary inquiry which is that thick, which even the Health Select Committee, though itself was rigged with very pro-government members, really couldn't stomach the lack of data and evidence that were being provided and the shifting focus. But nevertheless, so we've got capacity, we've got treatment, we've got, what about this quality of care and innovation? After all, the private sector is much more innovative than the public. However, when they try to look at quality of care, and this is the government's own department for National Centre for Health Outcomes, remember health outcomes are very big in your executive as well, they found that the late delivery of care data, poor quality, variation in data collection and completeness rendered any attempt at comparisons futile. So they couldn't compare themselves with the public sector, let alone know what they were doing. But the health minister is Lord Warner, who's got a place on many of the private for-profit corporation boards, he does that in his spare time, said he found this analysis heartwarming. And it was presented unquestioningly by our national media, who didn't bother to look at the first report. They simply took the ministerial statement, which said the report's analysis is heartwarming. So this is the quality of care. Now it's very interesting, the government, when it set this up, set up a completely parallel system in the executive with a commercial directorate. The head of that had come from a prison company and a facility management consultant, Amy. Never had any experience in the health sector before. He was a Texan and he led the commercial directorate and placed all these contracts out. And they also ran their own data collection and quality performance system in total isolation from the public system. Well, you can see they weren't exactly efficient at either the data collection or the monitoring. And the Parliament, the National Centre, tried to repeat these reports and has found that the data had not been collected so that they couldn't look at quality and performance. And indeed, most of the data sets which looked at clinical quality were marked not applicable, scored out by the private sector. So I think this evidence is really important, and when you're going in, you're going to have to look at the claims the government's making around capacity, additionality, etc., etc. Now this took us a year and a half to do this work because so much of the data wasn't there, and we had to do so much through freedom of information. Meanwhile, you've got the Parliamentary Select Committee having, unlike your Royal College of Surgeons, ours hasn't been captured. There's a very strong commitment to the public system. It's the one they trained in, they grew up in, they understand. Very, very committed to the NHS. And they were appalled, the Royal Colleges, at what was happening. And they brought report after report after report forward to the Health Select Committee. So did the Medical Litigation Authority. So did the lawyers. And yet, what happened? Parliament and the Department of Health dismissed their reports as anecdotal. Now, I'll remind you that when one whistleblower blew the whistle about paediatric mortality in Bristol, it launched a national government inquiry that ran over 4 years to millions and millions of pounds. He blew the whistle not with data, but because he was worried about quality of care. When you've got the Royal Colleges, the nurses, the lawyers, blowing the whistle with account after account of negligence and poor quality of care, it's dismissed as anecdotal by the government. So what about value for money? Well, you can't look at value for money unless you can look at costs. And what we do know is that the private sector has been given at least 11% above the NHS costs, but they were also getting tax breaks and government grants. But when the Select Committee, the Parliamentary Committee, tried to look at value for money, they were refused the value for money, and they were told it was commercial and in confidence. So the Select Committee said, well, that's fine, let's just see your methods, your methodology. And they were told again that it was commercial and in confidence. No doubt it had been drawn up by the private sector. So there were no data to look at value for money, which is one of the key justifications. So there are no data on this programme. And this is why, but we do know that very few risks have been transferred. So when the government brings the private sector in, not only does it give it grants and tax breaks, but it also says we'll buy it back or we'll place more contracts in the future. Medical litigation, the risks of things going wrong, is now being underwritten by the government. So when the private sector, and many patients ended up having cataract surgery and going blind, many more than would have been expected in the private sector, lots of litigation cases, private sector doesn't have to cough up anything. It's the public sector and the health service that will have to pay. The other thing that's very nice is that you don't get to go to the private sector unless you have special treatment protocols. So the private sector is able to cherry pick and cream skim quite legitimately. So they pick the profitable, healthy patients, which have also implications for training, for teaching. Of course, if anything goes wrong, that's why it's very handy to have co-location. They can flip back into the public system, where all the expense, the chronic illness, the chronic care, the intensive care unit can be picked up. And of course, they have the benefit of the public system of training and support, although they now want that budget too. So more money is being moved out as you run the system down. Now, the Independent Sector Treatment Centre programme has real parallels, I think, with the policy of co-location. And I think it's really worth looking at what the government's saying it's doing and what evidence is presenting for it. All the evidence in England is it's quite catastrophic. And there's a very good parliamentary inquiry sitting there, even if its conclusions are incredibly feeble, have been deliberately muted by the government itself. But yet, last month, we had the Confederation of British Industry, which is promoting these independent sector treatment centres, and it came out with a report called Sticking Plaster Reform. It's very angry because it thought that the government might not place any more contracts because the strength of public feeling is so strong against these and professional feeling. And in this report, they claim that the Independent Sector Treatment Centre has conducted more than 170,000 operations, increased efficiency and productivity, length of stay, lower complication rates, competitive pricing, value for money, risk has been transferred. And as I've shown you already, not one of those claims can be substantiated, either because the data aren't collected or because the government has refused to provide the data. So what was the basis of their report? Well, their report sits with patient satisfaction. 97% of them were satisfied because the hospitals were clean. Well, actually, satisfaction is not a good measure of quality of care. It tells you nothing about quality of care. And of course, you are going to be satisfied if the private sector has been given so much more and has so few patients going in that it can actually afford to keep the hospitals clean and give you really great food. So, and I should say that the occupancy rates are very, very low from what we do have from the few contracts that we've seen. In some centres, they're treating 50% fewer patients than they're actually being paid for. So we do have some local data. Am I running over time? Okay, because I was just going to come through to these P3s. So this is co-location when the private sector appears to put the money up front in those facilities. The other type of privatisation is the public-private partnerships or private finance, where you're taking your public infrastructure, your roads or your schools or your buildings, and you're transferring them to the private sector. And you're becoming the landlord, the private sector is the landlord and you're leasing them back. Again, you've got to look at evidence there. It's not new investment, it's debt, and that's the thing to remember. Some of you will have seen a slide like this before. This is what the private sector is raising, the green, but this is what you and your children and grandchildren will be paying out. So you're really in long-term hock to the private sector. This is wonderful for the banks, it's wonderful for the shareholders, because the government is guaranteeing to pay for 30 to 50 years this money out of the budgets which pay for hospital care, primary care, community care, and of course your schools and roads, etc. So this is the P3 program. So this is, if you remember nothing else, remember this figure, and you don't need to be good at arithmetic to see that the private sector philanthropists are putting in far less than they're taking out over the 30 to 50 years. And of course the government justifies P3s saying that it's competitive, value for money, brings additional capacity, additional investment. Again, you have to look at each of these claims as we have done, and it's all on our website. But the key thing is that because you're taking so much more money out to pay the bankers, the shareholders, you've got far less to pay for services, and you're having to raid the budgets of the hospital and primary and community care, which means major reductions in staff and a drive to centralisation. So if you take money out of the system, you have to actually downsize your public service. And this is a major driver to privatisation, is the P3 process, where you say we're going to go from 3 hospitals into 1. And of course, at the same time, you're taking more money out directly into the private sector. You've got even less as a driver for even less money. So you've got even more drivers for centralisation. So the drivers for centralisation are privatisation, through P3s and through direct contracting, because more money is being taken out of the public purse and poured in this way. And these drivers for centralisation will continue, not just this year, but next year and the year after, and you will find increasingly that you will have fewer, less entitlement, less access, and probably more user charges. I have run badly out of time, but I just thought I would show you one thing, which is some colleagues of mine have shown. This is the Edinburgh where I work. It should have cost 180 million. It will cost the public purse 1.3 billion. And these are the projected dividends just for the shareholders who put in $500,000. They'll take home 170 million. But look at next door hospital where the shareholders put in £100 and will take home 89 million. Now that's not just, that's the shareholders, that doesn't include the bankers, and it doesn't include the fees that are being paid to the management consultants. The final thing I'm just going to touch on very quickly are all these consultants and advisors, and they're linked to the patient experience programme. One of the things the government will do very quickly is going to bring in management consultants and contracts to do patient surveys, patient responsiveness and patient experience programs. It will bring in companies like PricewaterhouseCoopers and management consultants to import these. Many of them are American, like the Picker Institute, and the government will use these patient surveys and these focus groups to actually justify its policy of centralisation and feed it in to the planning process and centralisation. So this is a very controversial one in Scotland at the moment that we've written to the Minister about. But the important thing is information, as you know, is the lifeblood of any public health system. If you don't collect it, or if you privatise it, you can't actually ever monitor equity or fairness or redistribution. And one of the most significant things about this is there are no measures to look at how resources are being spent in terms of beds, or staff, or services, how the population is getting to them. Everything is focused on output and quality, and it's a major critique that you need to master. So I'm not going to go far too much here, so I won't. I'll end here, but I think what I'm trying to tell you is that this globalization of the healthcare industry is really going global across Europe, Canada, Latin America, Africa, you name it. And while you're fighting your little local battles, these are the sorts of mechanisms and vehicle and language you're going to have to become very familiar. I think it's very important to look at the work that Canada's doing or India's been doing in terms of activism, because you will be able to improve on it, but also the research and the analysis is going to be very important. Australia, for example, looked at the corporatisation of general practice, and that's the other big agenda for Ireland. It's not just co-location and PPPs, but you've also got the corporatisation of general practice, opening all these different entry points. Anyway, I'm sorry if I've only served to depress you even more, but information is a very powerful weapon, and you're going to have to start to learn how to use it and how to learn the questions that embarrass politicians. And politicians won't care if you say, that University of Pittsburgh's got £100 million of contract, because they'll reply and say, well, so what? They're efficient and they're effective. They won't even care if you say that it's been done by abroad, because they'll continue to say that. That's one very important part of the activism. But another part is asking them for the evidence behind their policies, and that's where Paddy came in at the beginning. There's no evidence to support the centralisation, and keeping on challenging them. Anyway, I wish you good luck and good heart in the struggle to come. Thank you.